In this video, we are going to revisit the healthcare cost prediction case study. So in module 1, we already talked about all the data preparation. Now we're actually going to fit the machine learning models. And just to remind ourselves, this was a collaborative project. We were a team of 8 trying to predict healthcare costs. So the contribution of this work was manifold at the time. So we were doing this is published in 2008. We really wanted to advance healthcare cost prediction. So we wanted to do it at scale and in an out of example experiment, which was uncommon at the time. So thinking back to module 1, when we talked about the importance of splitting up your data into training and then validation and even test data, that's exactly what we did here. And then from a business perspective, we wanted to gain insights into the drivers of high healthcare costs and contribute to case management. We already mentioned in a data prep video that since we have learned about the dangers of using healthcare cost as a proxy for health status, and that's what these last bullet points are, that there's huge potential for bias pitfalls by using, again, healthcare cost as a proxy for health conditions, because we know that different demographic groups have very different utilization patterns at the same level of health, and therefore, even though they're at equal health, their healthcare costs are very different. But we're going to set that aside for now and talk about how we fit these machine learning models. So this was the experiment that we had. So we had 2.4 million individuals in our database. However, we required that each member had at least 10 months in 2 periods. So what we called an observation period, where we can, view whatever is happening to the patients, and in the result period, for which we are trying to predict the healthcare costs. And the reason why we required them to have at least 10 months of data in both periods was really if we have no data in the observation period, we don't know anything, and the best we can do is just to predict the average healthcare cost for you. And we require them to have 10 months in the observation period, and that's really a function of limitations of claims data, because, for example, for that data set we were working with at the time, we couldn't see if a patient stopped seeing a doctor or if the patient died. So therefore, we made sure to have 10 months of data. And again, we split it into learning, validation, and testing. We did a lot of training on the learning part, went back to the validation data to see how our model development was going. And then only once we were really happy with the model and the output at the very end of the experiment, so really at the very end of 2 years, we actually took the test data and tested the models on the test data to be as objective as we could about the model's performance. So we did a lot of data modeling that we talked about before. One thing that we did in order to be able to apply classification trees, which is the part of the theme for this week, was that we took everybody's healthcare cost and we put it into buckets. Buckets from 1 low cost to 5 very high cost. And the way we constructed these buckets was that if I would sum up the healthcare costs of all members in each bucket, that sum was about the same. So you can say that each bucket in terms of healthcare cost holds equal value. So for our classification trees, we really, our dependent variable, what we are trying to classify is the members' healthcare cost bucket. But then we did some translation back to healthcare dollars to be able to use some more typical error measures for prediction, and also to be able to compare our result with what had already been published in the literature and what the competition of our collaborator Dito Hawkeye was publishing as their performance. So we used 2 types of models in the end, classification trees and clustering. You're already learning about classification trees, and then I will explain a little bit the clustering part. So what you have learned about classification trees is that if we have very simple data, so let's say the only thing we know about the patient is whether he or she is diabetic and whether they have a cardiac condition, and then we have the result period cost bucket. So then our algorithm might find out that the most important thing when it comes to predicting the healthcare cost bucket or classifying our patients into healthcare cost buckets is whether or not they have cardiac disease. So the tree might start by dividing the members into those who have a cardiac condition and those who do not. Then the tree looks at everybody that has a cardiac condition, and the algorithm asks the data, okay, is there anything else that can explain variability in the healthcare cost bucket? And the answer might be yes. Whether the patient also has diabetes is important. So we might split again on whether the patient is diabetic. So then we do the same thing for the group of patients who do not have cardiac disease. Let's hope they don't have death. But for the group of patients who have cardiac disease, and the algorithm asks the data again, okay, is there anything else that can help explain variability in healthcare cost bucket? And the answer might be no, and then we might assign buckets to each of the end nodes. So maybe my cardiac diabetic members are my class 5 buckets, cardiac disease, no diabetes, maybe bucket 3, and no cardiac disease, maybe I predict or classify all the patients that end up in that node as healthcare cost bucket 1. So with that, let's see how these trees worked on our data. What is interesting was that really all the first splits in the data are on the healthcare cost. So you can see here the top split on the tree is whether the patient spent more than $4,000 in the 24-month-long observation period or less than $4,000. So if they spent less than $4,000, it means or reflects that they are relatively healthy. So we're putting all of them in bucket 1, the cheapest bucket. If the patient spent more than $4,000, here we can say something else. And the next step is to ask whether they spend more than $40,000. We split it up. So then we have those who spend between $4,000 and $40,000. And then we have those who spend more than $40,000. And then we keep on going. And as we go down the tree, we can see more and more clinical information play a role in driving the cost prediction. So we've been splitting and splitting and splitting, and we arrive at this node that says the last 6 months. And here we say, okay, if the cost in the last 6 months is less than $1,000, I'm going to put all of you in bucket 1. So there might have been something going on with the health of the patient, but in the last 6 months, it seems to have recovered. At least it's not having expensive procedures done. So we are going to label those as low risk or low healthcare cost patients. But if you are spending more than $1,000 for this subgroup of patients, we next look at one of the clinical rules. And this is a clinical rule indicating both asthma and depression. And then we actually put you in the highest cost bucket. So that's the number 5, what the number 5 there represents. If you are not depressed with asthma, the next thing we look at is another clinical risk rule, is whether you have had a hyaline injection. This may be a predictor that you might need a knee replacement in the result period. So if that's the case, we put you in bucket 5. If not, we look at the primary chronic diagnosis. So if the reason behind your highest claim is of chronic nature, we are going to put you in bucket 2. If not, we look at whether you have an acute spending pattern, as we discussed in the earlier video. If yes, we're going to put you in the lowest cost bucket. If not, we're going to put you in the second cost bucket. So that just gives you an idea of how these what these trees look like when predicting healthcare costs. Here are some examples of the class 5 members. So for example, if you look at the second rule, it says if you're under 35 years old, between $3,300 and $3,900 in claims in the observation period, you have a cardiac disease but no office visits in the last year, we predict you to be in a bucket 5. So you might think, why am I predicting a relatively low-cost patient who is 35 years old as a risky patient? It's because they don't have an office visit. So basically, this might be a ticking time bomb. This is somebody with a cardiac condition, but is not receiving adequate care for their condition. So that's just one example of the groups of patients that we identify as potential candidates for reaching out to based on these trees. So the second approach that we selected in the end is a clustering algorithm. And the idea here is that if we manage to cluster together similar patients, then their futures might be similar. And what is interesting in our approach is that we took a two-step approach, a little bit inspired by what we saw in the trees. So what we do is that we run the clustering algorithm twice. So first we run it just on cost information. So we try to put or group together patients who are spending their healthcare dollars in a similar way. And once we have these groups of similar patients in the way they spend their healthcare dollar, then we run the clustering algorithm again, splitting those into smaller groups, but this time using diagnosis, procedures, and drugs, and all the clinical information. And then those are our final groups. So then we have small groups of patients that are both similar in the way they are spending their healthcare dollars and similar in their conditions. And then we say, okay, based on the members of the training data in those groups, we use their outcomes in the result periods as our prediction for the members of the validation data, and at the very end, the testing data. So basically the training members, their average costs in this group becomes our prediction for the validation and testing data. So here we have a group of, if I remember this correctly, 63 patients. And what we are looking at here is on the x-axis are the 12 months, the last 12 months of the observation period. And on the y-axis, we have their total spent in each month. And when we look at this picture visually, we can see there's very little happening until the last 6 months of the observation period. So then these costs start picking up. So for these 63 patients, we then ran a clustering algorithm, and it took these 63 patients and split it into two groups, cluster 1 and cluster 2. They both have in common that there's a lot of lab work, and they both have surgical days, which might explain these spikes in healthcare spending towards the end of the observation period. But then we see something very different. The reason for the surgeries are very different. So we can see in cluster 2, they are very high or very common to see physical therapy codes. So what these percentages represent is the fraction of members in the cluster that have that code. So we can see 72% of them had physical therapy, 66% of them had orthopedic surgery, 38% are already in rehab, 24% of them had been complaining of back pain. So basically these are patients that had musculoskeletal problems. Majority of them underwent surgery, majority of them are receiving physical therapy. So this is maybe a group of patients that are low cost in the result period because they have already kind of gone on through the acute phase of the disease or their condition and are on the recovery side. In contrast, if we focus at the lower part of this table, for cluster 1, we can see a high fraction of the patient has injectables. There's a lot of pathology, hematology, oncology, infusion, number of different cancers, so both cancer therapies, but then breast cancers, leukemia, lung cancer, skin cancer. So basically what we have here is a group of patients with recently discovered cancer. And why do I say recently discovered? Because there's very little going on until the very last month of the observation period. So we have a group of patients with recently discovered cancer, and they're probably going to be high cost in the coming year. So for that group of patients, we predict much higher cost than for the back pain group that are now recovering. So how did we do? In terms of kind of overall accuracy, we called it our hit rate. So we correctly predict the right cost bucket for 84% of the patient. We are super good on the lower cost bucket. And that's really driven because thankfully most of us are healthy. We continue to stay healthy. So predicting healthy patients to stay healthy is the easy part of the prediction. So we mostly get that right. And you can see that our prediction kind of is not as good as the buckets go up. And then if we compare that to a baseline of just cost repeats, meaning if you're bucket 1 in the last 12 months of the observation period, I'm going to predict you to be in bucket 1 in the result period. We can see kind of the same thing for that low cost members, the bucket 1. Our models can't do anything better than that. But if we concentrate on the last bucket, we can see that only the baseline saying just, oh, everybody who is currently very expensive because it's going to be very expensive next year, the accuracy of that is only 19%, and we more than double that with our clustering approach and almost double it with our trees. And then in terms of just prediction error, the story is the same. We can see the average prediction error is about $2,000. The clusters beat out the trees a little bit, and both really beat the baseline by quite a bit. And again, especially on the expensive patients, we do a lot better than just saying healthcare cost repeats. So we compared our results to what was reported in the literature, and we found that we did a lot better. So we managed to publish the paper about this. And we also compared to a leading software at the time, and we managed to do quite a lot better than that. And we beat the baseline. And one thing maybe that's worth kind of mentioning here at the very end is, so in our course, we talk about the baseline. And what is the baseline for prediction? Well, it's the predicting the average for everybody. So noteworthy here is that we took that idea further. So we said, okay, my baseline is not just going to be predicting the average for everybody. I'm going to make it a little bit harder. So what can we do? What is an easy prediction that we can do without any machine learning, right? So that easy prediction is just say, okay, if your total cost in the last 12 months was $1,500, I'm going to predict that your cost in the result period is going to be $1,500. So it's a much stronger baseline, and still we beat it quite significantly, especially for the sick patients. So to summarize, clustering had an advantage over the trees, especially on these high-cost patients, which are also the patients of interest. One thing that is super interesting is that we ran this, if you recall back to the video from module 1, we were running these on patient vectors that had about 1,000 features. If you are just clever in the way you utilize the cost prediction, you can get more than 90% of the accuracy. So what I'm meaning by that is if you take all the cost features, so the acute pattern, the chronic pattern, the spend in the last 12 months, and you only use those features to predict future healthcare costs, you get almost all the way there. So I don't remember if it was 93% or 95% of the accuracy, but you're very, very close. So sometimes it's not about gathering all the data in the world that you can get, but really thinking about what are the features that best correlate with the outcome? How can I best represent or summarize the data to then predict the outcome. So you can think about what we did earlier. We had, 13,000 or so diagnosis codes. We got that down to about 200 disease code groups, right? So we discussed that in an earlier video. You could even take that further and say, okay, let's just simplify and let's just count up the number of chronic diseases you have and summarize that into a single variable. So that's another idea of how we can take all of that data, simplify it to really drive our predictive performance. And what we talked about was, clustering. Final thought. The clustering really had edge over the trees, but in the end, because of the simplicity and the transparency that the trees brought to the table, that was actually what was implemented in the product in the end.